in terms of what's the funding mechanisms for doing these things?
I can't speak to the funds. Once again, we will have to. This is sort of a conceptual idea, if you will, and it's something that we do, that ARC does, and we have a variety of programs. We partner with CMS. And sometimes CMS does something that's called coverage with evidence, looking for evidence to show the effectiveness of a certain treatment. So there's a variety of mechanisms that can be used. I can't sit here and promise any funding. I think the idea from this subcommittee was that this is a concept or a recommendation that the subcommittee might want to put forward as a recommendation to the Secretary.
The VA medical centers do this with chronic pain already in their health services research. So they look comparative effectiveness research within their chronic pain working groups and whether or not their chronic pain management style results in better outcomes than standard of care style. So the model is out there.
A potential an RFA that would go out to say our agency is interested in this type of work, and then you would bid out to see what type proposals could actually do that work. Is that the way it might work? Because I take it that's the way the VA goes, Dane, right?
They do it through the merit review system through their health services research.
We do it intramurally.
Oh, intramural.
Yeah.
And I mean, I earlier today described that we have two standing programs that are research networks. One is a primary care research network, the other is an integrated research network, and those work with task orders. In other words, we select who's going to be part of the network, and then we put out task orders, and the various components of the network bid on them. So there are different mechanisms that can be used.
And under health reform, there is significant interest and resources dedicated to comparative effectiveness research, as well as to components of health services research, and particularly demonstration projects to try to show some of these new ways of tackling complex problems, using the systems, harnessing.
So is there a way for our kind of advisory committee to get those opportunities out to the greater public of practitioners and researchers so that they can know about those opportunities potentially to kind of bid on contracts or submit grants? I mean, how do we hook up with the outside community to let them know about these opportunities?
That's probably a weeds question, because until it takes shape and is actually put out there on the street, if it is competed among existing centers, the public, other competitors aren't going to be invited in. If it's an open RFA or funding opportunity announcement, then, we would hit send to the CFSAC members who could help disseminate. We'd link to the website, blah, 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 blah. But, that's way down the road, because it's going to depend on how this is brought together to marshal and line up those resources in that direction.
Deborah?
And so at HRSA, we currently there's an RFA right now that's out on for CHARN is our comparative effectiveness network funding that's currently available, and so I know there's a search for organizations that would be interested in participating with us to look at comparative research, effective research. Now those will probably more likely be organizations that we already fund. So that network of programs that have experience with collaborative learning and quality improvement approaches would more likely be included. But I think in your request, I think by charging the HHS with figuring this out, then we would put our heads together and look at our different mechanisms, and then look at what kind of expertise and models currently exist to incorporate that into our thinking and planning.
So I think the premise is that the current treatment model is costing a lot more money than it needs to. And it's not effective. Right.
Besides that, it's making all
What other parts of healthcare are?
And I think it is perfectly reasonable for us to vote on this recommendation today, and that gives the time between now and the fall when we next get together for the various agencies to bat it around.
I forgot whether it got a second or not.
It did.
Was there a second? There was a second.
So I think-
Do you want
I
to
think it is-
reread it, or folks still, because we stayed pretty focused for late in the day?
I don't think we changed the language at all.
I don't think so.
I have it written down for you, if you
Good.
need it. The Education and Quality of Life Subcommittee recommends that CMS, ARHQ, HRSA develop a private and public demonstration. Now that "and" is debatable, "and/or" is fine. Private and/or public demonstration project to put into place diagnostic and treatment paradigms that would result in effective and efficient assessment and therapeutic care and result in improved health outcomes and better value of invested health care dollars.
Just a friendly amendment. It's going to be from the full committee, isn't it?
Okay. Way that first part.
And can you, I mean, demonstration project seems to me like you already know what you want to do. You just want to show it works, that some research, using the word research in there, would broaden what sort of things you could do with it.
Actually, research is going to narrow it. A demonstration project really is going to be more in the health services research arena. I think it's going to be more permissive of real frontline, and maybe my colleagues can correct me. It's research at a level, but what we'd want to avoid would be somebody positing something and then having to assemble the pieces. We're wanting systems already working to put the pieces together. They're not having to go find.
But if you, I mean, a demonstration project sounds like there's no controls. This is what you do. There's one way of doing it. It doesn't sound like you're comparing or analyzing.
If you want to do that, there's nothing to stop people from submitting a grant to NIH on exactly this same thing.
Well, there's nothing to stop people from trying to do a demonstration project. I mean, if we're trying to encourage the secretary to support
If you want
this
to
kind of
focus on the research, if you want it to be a research project.
But it can also compare existing billing and, codes or whatever. I mean, there are ways to data mine to get your comparisons. I mean, I frankly would hate restricting. I think the word demonstration project in today's environment is going to be likely to be accepted compared to something that looks like quote-unquote research. Maybe I'm wrong, and again, I'd have to look to Chris or Deborah. But I think where we've learned so much, I mean, the health disparities collaboratives were basically demonstration projects. Although there was a little research piece there, it was understanding, do these improve care, improve outcomes, reduce costs? Yes, yes, yes.
If you want to do comparative effectiveness research, you wouldn't call it comparative effectiveness research, you'd call it a demonstration project?
No, that's CER, that's comparative effectiveness. But all I'm saying is let's let the group come together, get their recommendation. Here's the language you want. I'm probably just tired. But let the agencies try to work to develop. Your focused idea there is to demonstrate that a more systematic approach, or however you might describe it, would improve efficiency, value, and that sort of thing. So it could be comparative effectiveness domain. It could be health services. Both have an R on the end.
Any further discussion? All those in favour? Opposed?
Committee will see these again, so.
So moved.